Youssef may not need much of an introduction actually, but obviously there's been a very eye-catching program under Bradford, Health Hearts, an award-winning program, which has already shown very impressive results in increasing the uptake of statin treatment. And the aim of the program, as I mentioned before, was to reduce cardiovascular deaths by 10% by 2020, which I think is a tremendous idea. I think it's worth saying that is it Beaini or is it am I pronouncing this correctly, or am I making a mess of it?
Beaini is fine. Yeah,
Beaini,
I don't mind.
Beaini.
Yeah, that's
but anyway,
fine.
Youssef Beaini then. Youssef has had some, if you like, exposure as a registrar to hospital cardiology, which has obviously got him all fired up in the whole cardiovascular prevention area. You're trying to put all your former colleagues out of business, I think, with this type of effort. But I'm sure they'll be very supportive of that. They're all working very hard. So yeah, I think I'd like to introduce Youssef and ask him to take us away with your presentation.
Lovely. Thank you very much, Dermot, for that lovely introduction.
Okay.
So next slide, please. So Bradford's Healthy Hearts is a rather bonkers large-scale program that we've done in Bradford in response mainly to just being terrible in CVD outcomes. Next slide, please. And in Bradford, we're basically nearly the worst in the whole country for under 75 mortality for CVD. So, I mean, when you're 7th worst out of 211, you're basically the worst. It's not a good feeling. And 28% of all deaths under 75 are due to CVD in Bradford, 14% hypertension, loads of tens of thousands have cholesterols that are above our targets. And the CCG looked at this and said, well, what can we do? Money's tight, resources are very tight, we don't have GPs, we don't have nurses, but we want to do something. So there you go, Youssef Beaini, Chris Harris, team, do something. And then I just lost even more hair. But anyway, we had to think, and we thought, what should we do? Well, the first thing we thought, by 2020, we want to say we've made a difference. And we thought very carefully about this and how much do we think we can really achieve. And fortunately, we are well on the way to a 10% reduction in cardiovascular events. And we're just really desperate not to be nearly the bottom of the pile anymore. Next slide, please. So we started basically, this is quite a busy slide, but it just basically illustrates to you that I think in the crucial foundation of a large-scale quality improvement program is the basis, is the foundation itself. So we had a very wide-ranging engagement with a broad range of stakeholders. So in the CCG, all the different bits of that vary from area to area. Matthew Cripps came up and went through right care with us. We talked to our consultants across many different specialties, not just cardiology, peripheral vascular surgeons, diabetes, stroke consultants, and renal, and pharmacists, VCS, local authority, very important, and public engagement. From the beginning, we were saying to public groups that we want to do something large and different and to expect this. Next slide, please. And in the background, there was already a communications and engagement package there, prepping and preparing the way. Once that foundation was laid, then we said, well, okay, details, what we're going to do exactly, and we thought we'll split it into certain nice little chunks. So statin switches. Statin work with Q-risk, so people who've never been on statins before, de novo prescriptions. Hypertension, separate work stream, and stroke prevention in AF. There's a separate arm called the Clinical Assembly that just basically means working with the hospital on their pathways. We've done some great work on chest pain, I'm really proud of that, and we're looking at heart failure now, and we've worked a bit on atrial fibrillation, and just ignore the stuff on the right, that's just local incentives that we used. Next slide, please. And then once we made that plan, we're going to do statins and AF and hypertension, we said, right, okay, so how are we going to implement that? Well, we need some crazy local clinicians who are going to work very hard at this. So me and Chris Harris, and we're lucky, we've got good links with the hospital. Secondary care, they were wonderful. They were very supportive. We went and we said, we really want to do this big program. It's different, and throughout the whole process, they've been fantastic. We've designed program guidelines for each different work stream, regular education meetings for the GPs, and that has been, I think, critical to long-lasting behaviour change. We don't want to just do a bit of QI, a bit of quality improvement for a year, and then it'll peak and then it'll just peter off. We want a persistent, long-lasting, significant change to clinical behaviour. And to do that, we asked each practice in the whole CCG to nominate a clinical champion, and every 2 months we had intensive sessions with them, teaching, feedback, debate, new ideas, all sorts of things. A very good two-way process, and that was an MDT meeting, so a lot of nurses came to that, some pharmacists. One of the most successful healthcare professionals in the whole program has been a pharmacist who's got 100% anticoagulation of AF. She was amazing. Next slide, please. And so furthermore, after that, we worked with a regional clinical network. That meant a little bit of working with myself as also the one of the GP advisors, and some great support from our clinical lead at the time, Brian Power. And I think this next bit was really important. IT has been so important and has taken up so much of my time, but the output has made things really easy for the GPs. We don't want to overload them, the GPs and the nurses and the pharmacists. We can't. They're just not going to cope. And we've done some very clever pop-ups and things like that. I'll show you later. Comparative performance, great. None of us want to be rubbish and at the bottom. And I think it's important to have small numbers of work streams and applied repeatedly and then stopped. We can't be too ambitious. We can't say do everything, because everything just simply can't be done. It's amazing what incentives can do, and just one iPad is fantastic and worked great. So worked wonders. Ultimately, this was owned by the practices, and they agreed that there was a problem, and they were very, very much involved from the ground up, and I think that was really important in engagement. We wanted to work at scale. We didn't want to overload the clinicians, as I said, and there was a lot of passion and enthusiasm there. Next slide, please. So we thought to ourselves, right, what is the target outcome, and how can we try and be clever and different and smart about this? And does that mean that we need to amend clinical guidelines locally to achieve this? Next slide, please. So we focused in that way with smart aims on cholesterol, AF, and hypertension. So I'm not going to talk about atrial fibrillation and hypertension today and bore you. I'm just going to talk about cholesterol. So next slide. Next slide again, please. So when the biggest scale work that we've done in the 3 arms has been on lipids. And when we looked at the amount of work that we did with the statins, we would need an extra 26,000 to nearly 40,000 appointments just for that work stream. And then if you look at the overall eligibility of patients now with the new NICE guidance, with Curious 10 to 20, an extra 4.5 million patients in the UK, I estimated that would mean something like an extra 80 to 120,000 face-to-face appointments. Where on earth is that going to come from in any of today's primary care setups? It's just not going to happen. And NICE do mention at the end, yes, there is a recognition that there's limited capacity in healthcare, and I think it's up to us to translate that into what can we do locally. Next slide, please. So I used to have hair, and when I looked at the amount of appointments we would need, my face was like this permanently for weeks on end, and I lost all my hair. Next slide, please. So what did we do with statins after all that stress and losing hair? So it was the same multifaceted approach that we've done for all of our work streams. First, agree the protocol with secondary care. We thought, right, nice guidance is the aspiration, but we don't have the capacity to do anything like that. So what should we do? We either do nothing, or let's do a simplified version of fire and forget. Primary prevention, 40 milligrams, not 20, an already starting dose of 40 milligrams to achieve better results, and more in keeping with the US trend of direction of travel as well. And secondary prevention, 80 milligrams, as Nice says. And working at scale with letters, not face-to-face consultations, to change treatment. Supported by a website, YouTube videos, people like me and our consultant colleagues talking about CVD risk and statins and etc. Supported also by the comms package and lots of patient education sessions. I went to so many different patient participation groups, and we had district-wide education sessions, and we sent, therefore, next slide please, loads of letters to thousands of patients without seeing them. And clinicians and patients both said to us, what, are you sending letters without seeing patients? And not all of them looked as cute as this little baby. But when we got into the details of why, it became a very interesting discussion. Next slide, please. And that resulted, that large-scale, at arm's length approach resulted in 6,000 people having their simvastatin switched to atorvastatin within about 3 months. And it was, you could say, well, we don't know who's taken what, and are they adherent, are they not? Well, when you measure cholesterol, and we just measured it in a small number of patients who had the data, we saw over 0.5 millimole of LDL reduction, and a lot of patients didn't have an LDL, so they had just a total cholesterol done. And again, that was about the same ballpark. And the stats there are clearly significant, the p-value of 0.001. Next slide, please. And this was really easy for the GPs. They simply had on system one list of patients to do, and all they did was open the list, right-click, do something called a bulk switch. It's very easy, and it takes 1 to 2 minutes. I timed myself, and I think it was something like 60 seconds that it took me. This is not onerous. A little bit more time for the admin people to put letters into envelopes, okay, but for the clinicians and the nurses and the pharmacists, very, very streamlined. Next slide, please. And then we saw the numbers of patients who are needing interventions just going down and down and down steadily. Next slide, please. And moving on to Q-risk, so we know that nice guidance has significantly increased the potential population now for lifestyle advice and statins, and in Bradford we estimated that 14,000 were already coded, but a huge number were not yet coded. And what on earth do you do with, again, that huge cohort? So we applied the same principle at scale work with letters to all of those, well, not to all. We selected very carefully a subsection of those patients who could be treated safely and receive a statin at scale. And preliminary figures showed a very large proportion actually took the offer. Next slide, please. Early results for that, again, you could talk about adherence, but again, the early results were over about 2,000 of those 7,000 patients, a 0.39 millimole reduction in cholesterol. Next slide, please. So to date, in total, our program, we've switched 6,000 people onto atorvastatin, more powerful statins. We've started 7,000 patients with a raised Q-risk on statins. With atrial fibrillation, we anticoagulated more than 1,000 patients. The hypertension arm that we haven't talked about as well, we've found another 2,500 hypertensives, and in just 12 months treated another nearly 5,000 patients to a target of 140/90 blood pressure. So we've done a lot of other things as well as the lipid work. So in total, over about 2 years and 21,000 plus interventions. Next slide, please. And what's that done to mortality? Well, we've got early data. So if you look at the program before Bradford Healthy Hearts and then the program and the results after Bradford Healthy Hearts on the right, we've got 15-month follow-up. And this is mortality. Next slide, please. So now at CCG, we reduced mortality. We saw mortality reduced by 6.6%. In a neighbouring CCG in Bradford City, there was a diabetes program, and they've got a reduction in 6.5%. And in another neighbouring CCG, there was a small increase in mortality. Next slide, please. More interesting, though, was emergency admissions, so MIs and strokes. And again, we can see on the left before our program and on the left, on the right after the program started. Again, 15 months windows here. Next slide, please. And what we did is before the launch of our program, we retrospectively compared the non-elective admissions per month between Airedale, Wharfdale, Craven CCG and ours. And the p-values showed no statistical difference between the two groups. Next slide, please. After the launch of Bradford Healthy Hearts, we saw a reduction in emergency admissions of 8.1 per month per 100,000 population. P-value for that, again, very significant, 0.003. Next slide. That translates into an absolute figure that observed that we saw of 211 fewer MIs and strokes over 15 months, the first 15 months. Now, it's a large system. It's like any large ecosystem. It's not a randomized controlled trial. It's real life. But we know that there was no other large-scale quality improvement CVD program in our CCG during that time. So we feel that the only reasonable conclusion is that that's related to our program. But of course, it's not an RCT double-blind. Next slide, please. When you look at the very conservative NICE estimates of stroke, which we know are probably 50% of what we might actually expect. But anyway, if we go very conservative, the gross savings on those observed reductions would be 1.5 million in the first 15 months. The program cost about 300,000 in that time, so net savings to the CCG of 1.2 million in just over a year. Next slide, please. Now, I'm trying to keep this quiet, but we did actually have to bribe the BMJ quite heavily, and then they said some really nice things about us. Inspirational leadership at scale, taking forward ambitious targets, things like that. It was, joking aside, and it was really, really lovely to have some independent scrutiny of what we've done and some support. So it was lovely to see that. Next slide, please. And so what I say to my colleagues now is that I think this was a population-based approach. It was really important to have engagement at all levels and across a wide range of organizations. But you know what? A lot of the programs that we have now, please see your GP or nurse, we just can't sanction that or cope with that in primary care at this scale. So it has to be something different. It has to be something innovative. We also absolutely flogged IT to produce what we wanted, and it was such hard work, but the outputs were so useful, and the feedback has been great. And I would just encourage my colleagues, be ambitious, be brave. You can do things at a very large scale and satisfyingly make a significant difference, even in the current climate. Thank you very much. And my colleagues and co-conspirators there.
Yeah, that was great. Thank you very much to Martin for the presentation. Just see if I can get myself back to where I was meant to be here. So I'm sure there'll be lots of questions, you know, from others about this. But just again, just to start the ball rolling, I think we saw that you actually did this large-scale switching. Presumably, this would have involved many of the patients who would have been involved in this would have been secondary prevention and perhaps a fewer number of primary prevention. So you've got people who probably already sold on the idea of being on statins, and in fact the switching would possibly be seen as an improvement in you know, what they were already getting. So I guess that would have been maybe pushing against an open door. So did you actually look at the sort of you know, the demographics of the people that that you know, did get switched?
Yeah, from memory, it's a while since I looked at this. I think actually it was 5,000 primary and 1,000 secondary.
Really?
But, yeah, but I'd have to go back and check. But the main thing was that regardless whether it's primary or secondary, the patients said to us, "Oh, you switched us 6 years ago from Lipitor to simvastatin. That was for, we know that was for cost. Is this for cost?" And we said, "No, this is for efficacy." Yeah. And as soon as they heard that, they said, "Oh, great, thank you, great, no problem." And the pushback was really very little for the switch.
Well, yeah, I think I could imagine it would be.
So some of them said, "Oh no, I'm not doing so well on atorvastatin. I'd rather go back to simvastatin." But it was a small number, and we saw those nice reductions in cholesterol. Now, the Q-risk work with de novo prescriptions, patients who are statin naive, or we chose patients actually who are statin naive, is a different kettle of fish. So that's more challenging, isn't it?
Yeah, I think it is. I mean, one of the you know, the things that immediately strikes me is that 40 milligrams of atorvastatin is generally well tolerated, but we do recognize that the reason NICE chose 20 milligrams was to try to, if you like, reduce the likelihood that you would end up, if you like, prescribing, you know, a dose that was going to yield side effects, you know, in a larger number of people. That there is a statistical increase in the number of abnormal LFTs, etc., for instance, on 20 milligrams. And within this, you've got both males and females, and you've got a wide range of ages. And you may indeed be probably, with Q-risk, pulling up older people rather than younger. And the people that pitch up, if you like, to have, if you like, Q-risk done are more often females rather than males in the older age group. So, you know, I suspect I kind of, you know, maybe would be less comfortable about initiating on 40 milligrams in that group of people. If it was the rugby player, you know, who's just retired and he's 105 kilos, I would have absolutely no problem even put him in 80. But it's the sort of, it's the 75-year-old spinster who's 50 kilograms and she's on all sorts of other stuff with slightly bit of CKD.
We excluded quite a lot, so low BMIs, low body weights, no recent body weight, no recent LFTs. Oh gosh, so many things. Warfarin completely excluded.
Anybody? You mentioned. I know that we probably get lots of questions, but one of the things I just thought you'd be worth asking is about. The fire and forget was what was really done originally in the 2008 NICE guideline with simvastatin, and as you know, that was kind of abandoned in favor of a high intensity approach with a bit of tailoring to try to improve concordance by measuring to make sure something had happened. So obviously you have measured to see something has happened, but are your patients getting an annual follow-up, you know, to offer them you know, an MOT, so to speak?
So it's the standard long-term condition annual review.
Yeah. Well, certainly, I think the persistence is going to be one of the big things. You know, your 0.56 millimole per liter, I think, is quite impressive, given it was averaged over a large number of people. But I guess within that, you're going to have a lot of variation of individuals. One anecdotal, going from 8 to 3, those are the ones, I suppose, where the primary care team are going to punch the air and say, we made a difference on that one. But yeah, I think the fact is that you are getting the message out to large numbers of people who with the best will in the world, you know, are not going to necessarily get FaceTime with either you or with their practice nurse anytime soon. So.
No. So, I mean, eventually you would see those, but if it's going to be piecemeal and face-to-face, it's going to be a handful per year, isn't it? So it's going to take such a long time to get to them.
Yeah, there's a question here about, was there any element procured or external support brought in to support all this work?
No, in-house.
Yeah.
Yeah.
And you mentioned the importance of doing the database searches in the GP systems. So was that all developed in-house?
Yep. CCG in-house.
So the CCG were able to sort of take advantage of a uniform, I suppose, set of computer systems and able to run those searches on everybody's practice database.
Yep.
Yeah.
They all signed up. And they all agreed to be part of the program, all 41 practices. Yeah. And yes, we're very lucky in Bradford that we've got one system. So I know that's not the case everywhere.
Yeah, I think, you know, you talked a bit about the power of big data to actually move things along. So what about, are there plans to one of the big questions around statins that people keep asking is, you know, how many of our patients that come in with a heart attack and get discharged in hospital on atorvastatin 80 milligrams are still taking it a year later or 2 years later? You know, those are the sort of questions, I suppose, could be answered by these approaches, and also the idea of possibly trying to get people to say, okay, well, look, why are you not taking your atorvastatin 80 anymore, given that you had an acute coronary syndrome, you know, 6 months ago? So I don't know whether that's part of the forward plans.
Forward, yes, definitely not at the time. It was just it was quite focused. But I mean, we got the pharmacists very quickly on board, and they changed from actually being a barrier to being a great ally, and that prompted a lot of raising of awareness amongst the pharmacists as well, and helped quite a lot of our patients. We then saw some kickback with, oh well, this one isn't taking their atorvastatin 80. Why is that? Was a horse pill? Why? And then there was that discussion. So yeah, that wouldn't have happened otherwise. So the whole thing had some very nice side issues. Yeah,
I think it starts possibly a lot of you know, dialogue going, and an individual patient may in fact be coaxed out of their shell a little bit about some of their issues that otherwise might not happen. There's a few questions coming in, and we maybe just take some of these. What does the average cholesterol reduction translate to in terms of absolute risk reduction for individuals? And I say that I think that, I mean, you might want to take that question.
Well, it's very easy to answer. You just don't know, because it'll depend on that individual's absolute risk to start with, and it's so varied that you just, it's difficult. So therefore, I like to focus on outcomes. And what are the outcomes really? I want people to live healthier and longer. Whatever that is. So really, I'm focused on what has that done for MIs and strokes and peripheral vascular disease and things like that.
Well, I mean, it is possible to give the Rory Collins answer to that question as well, and that would be that for every 1 millimole in your LDL, you could more or less say the same thing for non-HDL. I think I would recommend non-HDL as what NICE recommended. It doesn't require fasting, just a measurement of total cholesterol and HDL. But a 1 millimole reduction in that is going to give you, roughly speaking, 20 to 25% reduction in risk, and that's relative. But if you've got a 40% absolute risk at baseline, which would be your post-ACS patient, you know, that would be reducing that risk by an absolute of 10%. So half a millimole would reduce that by 5% right there. But I totally agree with you. I think you can make individual judgment based on people's baseline risk, and I say 40% is an estimate of the patient with cardiovascular disease. But with it on a good day, with the wind behind it, you'd expect that your high intensity statin therapy would reduce your non-HDL by 40%, which does give you a 40% reduction in relative risk. So you can then translate that into absolutes by knowing what the absolute risk on the patient would be. And you're obviously targeting those with 20% or greater risk as well. So another question was, were practices incentivized to take part? And were the pharmacists mentioned, were they practice-based or community pharmacists?
So the practices, because the program was much more than the lipids, it was 3 different arms and so large, the practices had some engagement monies. They needed to release clinicians regularly for these teaching sessions, and that would require backfill.
Right.
So each of the practices for a year got £5,000.
Right.
That's a fair investment. And there was a bit of a gamble initially because the CCG wouldn't know that we would do well. Yeah. But I think it's worked out very well for them.
Yeah. Well, I mean, I think it's you know, it's a very impressive results, and particularly if you know, the improvements continue, and particularly as the patients that do switch and do initiate continue to pick up their prescriptions. I guess that's as good a sort of an idea as to adherence. The outcomes in terms of whether they're taking the tablets and getting the benefits will obviously be more evident from the cholesterol and blood pressure, etc. Results.
And for the pharmacists, they were mainly community pharmacists that we engaged with. The practice pharmacists, the practice pharmacists who were working with those practices, many of them were already engaged in the program, but no, we reached out to the community pharmacists across the whole of Bradford, not just practice-based.
So I think there was some other questions, I suppose, that were listed here as so if you were advising other CCGs who wanted to implement a similar model, you know, where's the best place for them to start?
Easy peasy, I think. You always start with the easy peasy stuff. I think the statin switches were incredibly easy to implement. I don't think you would need engagement monies. I don't think you would need time. It's just something great to start with. You could make a big difference, measure it a year and a half, and then on the results, I think.
Well, in Newcastle and Northumbria, we actually, whenever the 2014 Gut Nice guideline came out, we decided to switch everybody from Cinva 40 to Torva 40, but on a rolling basis when they come back for their reviews. So you'd expect that it'll take a while to roll through all those. I mean, what you've done, I suppose, is a kind of, it's a bit like the vulture sitting on the tree branch saying, I'm going to kill something here. So you're actually going at it proactively. It'd be very interesting to see if we can get some searches done on our CCGs to find out whether, in fact, it did eventually, you know, come up with the similar improvements through more of a kind of a stealth approach.
A stealth approach,
So those searches clearly would be a good place to look for capability to do those things. Is that something that you're going to find there's going to be a GP kind of geek in every CCG that can sort of as a wizard on the searches that they're going to be able to put these together? Is it possible to share the scripts for the searches, for instance, or anything like that?
Yeah, I mean, I've already emailed, I don't know, I've lost count how many times now. I've got a package of files, the letters, the searches, the pop-ups, oh goodness knows, so many different things, and I just package them all up and I've sent them to loads of CCGs. York are going to start, I think, with their statin switch program. Catherine Griffith's going to have a go, and very happy to do that. I think this all boils down to leadership, doesn't it? And if you've got somebody somewhere in your CCG interested, then yes, there are people around like me and others who've done fantastic work. who, not saying I've done fantastic work, I'm saying the others have, who we can
I'll
learn from.
say it then. You've done
No,
fantastic work.
and
Somebody has to say it.
and it's just about that interest and enthusiasm, and I don't think it needs to be too onerous. So, but I think that's clinical leadership and identifying who it is. And I know Matt Keane is working very hard on national leadership forums, and I think encouraging that it has to be something that we encourage and we look to.
Yeah. Another question was, you know, do you think you're on track to meet your 2020 target?
I think we're doing a lot better than we thought. That's just in the first 15 months. We were quite surprised. So we've had a hiatus. Some CCGs will feel the same. Their clinical support units will have lost their contracts and things have changed over. So we're just adjusting to new providers. But that's going to be really interesting to see what is it, 2 years, 3 years, 4 years.
I mean, it's been in the northeast where I am. I think we're a bit disappointed that we've seen reduction in resources for the cardiovascular networks. You know, they've lost a lot of staff, and basically it's almost been like, oh, heart disease has been sorted now, and that I think what you've shown is that there's still a long way to go to actually, you know, to get you know, those eligible people, those people that ought to be offered these interventions onto them. You know, and the fact that some of them may simply be sitting there unless somebody comes and chases them for them, like you've done. It's never going to happen. So look, I'd like to thank you for your presentation. I think at this stage we need to get you, Youssef, to mute your mic and close your